Hear me? So good morning, everybody. My name is Dr. Susan Louw, and I'm a hematologist. So I work with our speaker from this morning. He's my professor, my mentor. I eventually became my colleague, and I hope he's also my friend. But he's a clinical hematologist, president of the South African Society of Thrombosis and Hemostasis. As we know, blood goes everywhere. Clots occur in all organs of the body. And this morning, this hematologist is going to speak to us about rare disorders. So the floor is yours, Barry, Professor Jacobson. Thank you very much.
Thank you very much. Thank you very much, Susan, and thank you, Adam, for the kind invitation to speak at your illustrious meeting. So you can see from my title, I have many bosses. I work in we have the rare disease unit, which is part of the Department of Internal Medicine, but I also work in hematology, molecular medicine, and I also have a post in surgery. So I've got many bosses. And these are my disclosures. And right, so now we're going to, I think I'd like to pay tribute first to the father of Gaucher's disease in this country, the late Dr. René Heitner. He was the first person to really put Gaucher's disease, and we're going to talk about all rare diseases, but mainly Gaucher's disease, on the map in this country. He fought tirelessly and endlessly to help children with Gaucher's disease. He was a pediatrician, and an absolutely amazing man, and a real fan of his. And it was a real loss to us when he died untimeously. So I'm going to start off a little bit about South Africa and the history. And I don't know how many of you obviously know that South Africa was discovered by Bartholomew Dyers in 1488 when he described the Cape of Storms. He actually was renamed the Cape of Hope, but it was originally called the Cape of Storms because it was so treacherous getting here. So he was the first explorer to sail to the tip of Africa. He was a primary influence of Vasco da Gama, who ultimately was first to land in South Africa. And he named the tip of Africa Cape of Storms, which we renamed it to the Cape of Good Hope. And during his last voyage, Dyers sailed to the Cape of Storms and encountered severe weather where he actually died. So it really was the Cape of Storms for him. Well, Vasco da Gama landed here in 1497. And the fascinating thing about Vasco da Gama's travels, and you can see how his travels, he started actually in Portugal. He went all the way down via the Cape Verde Islands to Cape of Good Hope on his way to India to try and get spices. But what is amazing that he could do this was because of the maps. So I'm going to spend a few seconds teaching about geography and maps. So this was the map that he actually used to get to Africa. Now, can you imagine? Look at this map here. You can see there what's a better slide here. This is the Indian Ocean and how it is portrayed. And we're going to talk about maps and why Africa has been neglected. But it was an incredible feat to sail all the way to India from Europe using this map. It is a phenomenal expedition. And this is how we see the map, how you get taught at school, the Mercator projection of the world. And you can see Africa looks quite small. But the reason we use a Mercator map is for navigation, because the navigation on the Mercator map is, a Mercator map, you can draw a straight line, which will get you which will be the quickest route to get to the area, which will be the rum line. And it's the easier way to navigate. Otherwise, having to change your compass the whole time would be very, very difficult. So that's why we are taught this projection of the world, but it's not at all accurate in terms of size. So if you look at the Gale Peters projection of the map, you can see how big Africa really is. Okay, and this is the most standard one that's used nowadays, the Winkel triple projection. But you can see Africa is really large compared to other countries. And if we look at rare disease in Africa, and it's always fascinated me because I was the African representative for education for ISTH, for the National Society of Thrombosis and Hemostasis. We had one representative, me. Look at all the other countries. United States, Spain, Portugal, France, Germany, Switzerland, India, Eastern Europe, which has got many representatives, India, Ghana, China, UK, Japan, they all fit quite nicely into Africa. So in terms of size-wise and population, we'll talk about later, we have been a very neglected area in the world from a financial point of view and from a saying point of view. So we're going to talk now a little bit about, we'll come back to that at the end, but what is a rare disease? So there is no single widely accepted definition for a rare disease, okay? Some definitions rely solely on the number of people living with the disease, and other definitions include other factors such as the existence of adequate treatments or the severity of the disease. So you can see there's two great differences in definitions. The Americans, who are very America-centric, define a rare disease as a condition that affects less than 200,000 people in America, not in the rest of the world or in a country, in America. And we'll come back to that. The EU's definition says a disease that affects no more than 1 in 2,000 people. So you can see already there's a vast discrepancy in what we determine is a rare disease. So rare diseases pose serious challenges in terms of both diagnosis and treatment. And this is the interesting thing from a drug development point of view, that legislation was passed in 1983 and in the EU in 2000 to reverse the previous neglect of rare diseases, to provide incentive for development of orphan drugs for their management. Because we all know the average cost to develop a drug in the world approaches minimum of $100 million and often close to $1 billion to develop a new drug. And that is because of the legislation that is required to get to these, to get through FDA approval. So the America decided to go around, to get around that, have said that if the disease is a rare disease, their requirements are far less stringent, and the costs to produce a drug are much lower. So what are the evolution of the previous challenges in rare diseases in America and United States? Well, one, improved diagnosis. A clinical suspicion, and that's molecular biology, can trigger now DNA testing of the appropriate gene panel. So that's been a vast improvement. Rather than having to look at phenotypic definitions of diseases, we can now screen people, and using gene analysis, we can decide, we can confirm or refute the suspicion. The other big thing has been these patient awareness groups. So we've got a very vociferous group of patients who have got rare diseases, who then lobby for their people. And the person in charge is in South Africa is a woman called Kelly Du Plessis. And she, unfortunately, is a child with mucopolys, with MPS, type 1 or 2, I'm not quite sure. And because these medications are so expensive, she has lobbied endlessly and formed a rare disease society and lobbies both the pharmaceutical, government, and the medical aids to make sure that initially her child, and now everyone with rare diseases, has access to these medications. So in Africa, the evolution has been hindered because we have no improvement of diagnosis because of the costs involved. So genetic screening is extremely expensive. If you want to do NGS screening on a bone marrow, anyone idea how much it costs? And we're now doing it as sort of a routine. It costs between 12 and 18,000 Rand per assessment for next generation sequencing. So these are expensive testing that we've now had to become involved in. And because of the stigmata attached to the diseases, that they're rare diseases, and we have much more pressing problems with HIV, TB, that these unfortunately, these diseases get put onto the back burner. And there's no legislation in place unless there is the power of lobbying. So the lobbying, for example, Dave Britton and taken over by Johnny Mashlangu have done a good job in fighting for the rights of hemophiliacs, who are also fall under rare diseases. So the cumulative impact on the rare diseases, because it's, even though it's a small number, it's estimated that about 10% of individuals worldwide are affected. So the big numbers for individual people, it's small, but the big numbers are, there's a lot of people involved. And approximately 80% of rare diseases result from a genetic mutation, but there might be multiple different genes involved, and there might be and different progression of disease. So someone with the same genetic mutation can have a very different phenotype as opposed to the genotype. So the scarcity of the particular disease combined with a limited knowledge often leads to misdiagnosis and delayed care, which in many cases may be fatal. So approximately 4% of the total world population is affected by rare diseases. And according to, there's approximately 3,585 rare diseases. We're not going to question you on all of them. In the EU, we said it's 50 per 100,000. In America, it's fewer than 200,000 people, or roughly 86 per 100,000. Unfortunately for Africa, we don't have exact numbers, and it affects a small population, or percentage of our population, but we just have bad statistics generally. So we're going to talk about Gaucher's disease to start with, and that's probably the disease that I'm the most familiar with. And there are three main types, types 1, 2, and 3. The prevalence is approximately 1 in 100,000. The annual general population incidence, the annual incidence is about 1 in 60,000, but in Ashkenazi Jews can approach 1 in 1,000. Formal diagnosis is determined by measuring the glucocerebrosidase levels in circulating leukocytes, and we confirm it by genotyping. We have a blood spot test that we send overseas, and that's actually sponsored by the pharmaceutical industry, and it's done for free for us. Differential disease includes other lysosomal storage disease, which can be found in certain hematological diseases like lymphoma, Hodgkin's lymphoma, and CLL. But the average time, so the hematologists are the most likely to make the diagnosis, often because of the associated thrombocytopenia. But it takes an average patient, this is in a first world country, about 7 years to get for the diagnosis to be made, which is quite scary, 7 years. And that's probably because of lack of awareness. Okay, so what are the classical features? And I'm sure you all know, well, hopefully some of you know, type 1, which we see the most common, splenomegaly, thrombocytopenia, anemia, high ferritins, a big liver, big spleen, and a gamopathy. Major covariables are family history, Ashkenazi or Jewish ethnicity. Having said that, the majority of our patients at our clinic are actually Black patients, Black African patients that have got spontaneous mutations. The unexplained presence of greater than 2 signs or one unexplained sign should make you think of Gaucher's disease. So if you have unexplained thrombocytopenia in a patient, even if they're older, don't automatically assume that it is ITP. You have to think, if you don't think about Gaucher's, you're not going to make the diagnosis. What are the symptoms? Difficulty in eye movement. They can get angiokeratomas, yellow spots in the eyes, anemia, fatigue, thrombocytopenia being very common. They can get joint pain. They can get difficult coordination, and there's an increased incidence of Parkinson's disease as the patients get older. They can have pulmonary hypertension, and they can have hepatosplenomegaly. And these are the classic pictures that we see on a bone marrow, as Dr. Louw will attest, who spends hours behind the microscope. Often gets missed, sadly. It's this tissue paper-like cells. You can see these tissue paper-like cells, okay? And we have missed cases even in our department. They get missed. They get seen, especially the background of HIV. People are so used to seeing C-blue histiocytosis, and they get missed. So it's not an easy diagnosis to make. It can be missed even by the hematologists. And most cases, you have to go back and see they had a bone marrow because they had hepatosplenomegaly, and you go back and really look at it, you'll actually find the cells. So you need to make the pathologist aware that you are looking specifically for gauches, otherwise they can miss it. So we can see with treatment, we have improved the survival of these patients quite dramatically. What about Fabry's disease? That's more for Graham. Rare of glycosphingolipid metabolism due to absence in galactosidase 1 alpha or alpha galactosidase. And there's type 1 and type 2, a classic and a later onset. It's X-linked. They get angiokeratomas, get burning pain. They get, it's a genetic test. They get cardiac and renal disease. And it's often type 2, it's often missed. And in adulthood, if you don't think about it, you won't make the diagnosis. Female seems to be only accurately diagnosed by demonstrating specific gene mutation, but you can do chronic chorionic villus biopsy at about 15 weeks to make the diagnosis. The incidence is quite rare. In Australia, it's about 1 in 117,000. Bob Desnick, who was the first man, I actually met him in New York. He was the first person to actually develop glucocerebrosidase for Gaucher's disease. Very interesting man, Bob Desnick. He's retired now. And he said ranged from 1 in 40,000 to 1 in 60,000 males. And 90% of adult males are actually symptomatic. But it looks like there's a lot of variants out there where people are asymptomatic, and they can go through their entire lives without developing symptoms. So it becomes a very difficult problem to manage these patients, because the medication, as we'll talk about later, is very expensive. I broke this thing. There we go. Right. So the symptoms can vary from 30 to 70%. So if you look at Fabry survival, treated versus untreated, the females, it doesn't seem to be much benefit for treating women, but you can see for treating males, you can increase their lifespan by at least 10 years. And that's a difficult sum to conjure up when the treatment's close to R1 million a year. So it's benefit, but you can see the males, if you treat them, you can improve their survival by about 10 years, which is significant for that patient. But females, the benefit seems a lot less. So in females, they say overall 15 years in women and 20 years in men, but if you look at the graphs, they're not actually that good. Pompe is a rare disease, continuing with variable disease rates. Most severely affected are infants within the first 3 months after birth, and they have cardiac problems and skeletal problems and weakness, and their life expectancy is less than 2 years. It's autosomal recessive. Both parents have to be carriers. There's an infantile form and a late onset form. And personally, I don't have any patients with this, but the pediatricians have 1 or 2 patients. You have to measure GAA activity, and you can do pre-implantation testing is also possible. But now, what about a disease that is classified in America as a rare disease? Sickle cell disease. So sickle cell disease in America is a rare disease, but by no ways in South Africa is it a rare disease. So it affects anemia. I'm sure you've all admitted patients into our unit with sickle cell disease. They're quite problematic because a lot of them are addicted to opioids, because we've treated their crises with opioids and we've made them addicts, and they are a major problem for us. But in America, they're a rare disease. So it's just sad for me that the Americans haven't gone towards spending more money, because they don't have to spend so much money to get the drugs registered. And we're stuck here only with one drug, hydroxyurea. There are different therapies which are now becoming available for gene therapy with Valoxetor and crizanlizumab. clinical manifestations, don't forget, from my point of view, they often get pulmonary hypertension and pulmonary emboli. And we make sure, we've missed a lot of cases before because the patient comes in and they've got acute chest pain and you think it's a pain crisis and they've actually got an underlying pulmonary embolism. So it behoves you to go and look for pulmonary emboli in these patients. Okay. Detailed clinical history and family studies, you do all know this. We're not going to go through how to diagnose sickle cell. But if you look at the sickle cell gene frequency, most commonly in Central Africa. But because of our open borders, we've got a lot more cases now in South Africa. And we admit, I would imagine, one a week, 1 to 2 a week that we admit with a pain crisis to our ward with sickle cell disease. So it's becoming very, very prevalent. Falls under rare diseases because it's the American rare disease definition. So it's an important but neglected risk to child survival in most African countries. And public health programs include newborn screening, health education, immunization are urgently needed. And there are pilot programs in Benin and Ghana, but they haven't really come to much, sadly. The poor data for other rare diseases in African countries calls attention to the urgent need for more investment in trying to raise awareness, diagnose and treat these patients. And there are gaps between optimal current management and the current reality in South Africa, making practical proposals to solve this problem. I'm going to take a short tour of what's going on in Africa and maybe in the world in terms of healthcare expenditure, because these drugs are very expensive, and we're going to just talk quickly about. So if you look at the population in total and per capita government expenditure on healthcare, you can see one of the best countries is actually Namibia. Okay, Namibia, because there's so few people per capita, they're spending a lot of money on healthcare, as is Angola, and interestingly, Tunisia. Okay, they're spending quite a lot of money per capita on healthcare. When it gets to the patients, we don't really know. If you look at where the money is being spent, a lot of these countries, most of the money is out-of-pocket private healthcare. So there are a couple of very rich people and they're having their own healthcare, and that's where the money is being generated. If we look at number of people who have access to modern medicines, okay, in the DRC, about 24% to modern medicines, but absence to innovative high-end therapies, about 1%. In Sudan, less than 1%. In Nigeria, and look at the level of reimbursement, Nigeria have an NHI, and God forbid the NHI ever comes into this country, less than 5 to 10% of the population is covered. Ghana have got an efficient system, but a targeted public price, and very little medicines actually get to the patients. DRC has no reimbursement. Sudan, there are two, a government sector for low to moderate and the private sector for higher levels. Very similar to this country. DRC NGOs produce a lot of the money, and in this country as well, the NGOs sponsor HIV medication. So NGOs, but only communicable diseases are covered. Malaria, Ghana, Tanzania, Nigeria have about 2 to 5% of private insurance. And in Sudan, most of the projects they're getting is from NGOs. For thalassemia and hemophilia patients, nothing generally, which is why a lot of these patients will end up coming to South Africa for treatment. If you look at how long it takes to get a drug registered, and we all know in this country it takes between 6 months to a year, sometimes longer, to get a new drug registered. Nigeria takes a year, Kenya takes a year, Tanzania 2 years. If you pay money, you can get it done a bit earlier. You can get a special import duty then, as we can in this country, but it's difficult, tedious, and expensive. What about just queries that that I went through the pharma industry to see how many people are actually asked outside Africa for treatment? Okay, And you can see just about no one. I know we've got one patient that we're managing now from Botswana, and there's one patient now in Namibia. So this is an old slide, but most places in Africa don't have it. So the treatment is all disease-specific, symptomatic, and supportive, genetic counseling and enzyme replacement therapy, and we're going to talk about how expensive that is. So if you look at the cost to treat Pompey's, which is a very rare disease, and compare two different countries, and you look at, for example, England, costs 194, this is per annum, 194,000 pounds, which is 3.5 million rand, okay? And in Colombia is 97,000 pounds. So there's a discrepancy between the first world and the third world payments. Okay, so there, in addition to the confounding biological makeups, there often 90% of rare diseases have got no treatment, and we need to try and expand that. And that has been, they talk about this. This is just the treatment challenges, and you can see rare disease active studies that because these drugs can be made and they are quite expensive medication, and the cost to produce them, to get them registered, has been markedly reduced. The pharma industry have now seen an opportunity and have started to invest more and more money into trying to find rare diseases. But once again, the cost to make them is expensive, and these drugs will remain, unfortunately, very expensive. So in the last few minutes, I'm going to just talk about GDPs and where we spend our money. So this is an overall GDP. I've only got from 2019. I don't have more recent, but you can see, obviously, countries have got the United States, Europe, and South Africa doesn't do badly in terms of our GDPs, but China, India, and Asia and Europe obviously have got high, and Australia have got high GDPs. Now let's look at total health expenditure in the world, okay, as a percentage of the GDP. So this is in terms of billions of dollars, $1,201 billion. And approximately in 2022, the world spent 5.5% of their total GDP on healthcare. It went down. I think this was due to HIV. It went up and then it's come down a bit. But now let's look at percentage of gross domestic product in selected countries. And this is all 2020. I couldn't get newer data, unfortunately. But if you look here, I don't know how well it projects. You probably can't see at the back. Adam can't see. He wants to sit at the back. But we'll wake Adam up. But Adam and Graham at the back there. South Africa here is right in the middle. 9.1% of our GDP we spend on healthcare. Majority of which is stolen, but we're spending 9.1%. So we are better than Israel, which has got first world medicine. We are better than Korea, which is very first world. We're right up there with Iceland, Czechoslovakia, Colombia. The worst country in the world is India in terms of their GDP. They spend nothing. Okay, they spend 3% of their GDP. I don't know if you've been to India. They have a huge discrepancy there. So they have first world medicine, unbelievable levels. I mean, I went to the hospitals. They're overtaking in terms of health tourism. You can go there and have your bypass done at about 20% of what it costs you in South Africa. Brilliantly well done. But if you're poor in India and you're indigent, you've got no chance of getting any healthcare. Okay? That's really terrible. And the other end of the screen, which is really way above everyone else, is 18.8% of the United States. So they're spending close to 20% of their GDP on healthcare, reflected by the fact that all the pharmaceutical industry target their prices at the Americans. Okay, that's where they're targeting their prices, because they're spending 18%. But you can see we're not bad off here. We just, if the money was spent properly and not stolen, it would be great. If we look now, okay, so you can say, well, it's private versus public, you know. So this is a nice one. It looks at government, which is what the government's paying, and then household out of pocket or voluntary payment, which would be the medical aids, okay? Unfortunately, I haven't got South Africa here on this slide, But you can see America, even what the government is spending, we will say, well, it's the private sector and the government is spending way more in America than anywhere else. So American government, their government pay for healthcare far exceeds the rest of the world. But you can see here that countries like Switzerland, which we think is so first world, a lot of the money that they're spending there is coming from out-of-pocket or health insurance. Okay? So that's an interesting statistic of where the world is spending their money. And here's a second interesting thing, which is a very sad thing, is where are people targeting their health expenditure? So you see that the majority of money being spent is on high income groups, and very little money, if any, in fact it's going down, is spent on low income groups. So expenditure on the low incomes is coming less, and that's probably a reflection of all the high-end medication that we now have access to, that very few patients in the low income groups are eligible to getting this medication. And that falls in the same for our poor patients with Gaucher's disease. You can see the current health expenditure in sub-Saharan Africa is on the decrease, not on the increase. But now, to cheer us all up, I'm going to talk about where we should be going. If you look at the annual population growth rate, and I think that's the world has sort of forgotten about us. So you can see that annual population growth in Africa is huge, okay? And in but mainly in Africa, where the population growth is going up. So this is the population of the world in 2023. You can see it's like a linear graph going up, which is phenomenal, okay? So in South Africa, in the world currently, there are about 8 billion people, and the numbers are increasing. If you look at, I've got my slide for South Africa didn't come out. South Africa has exactly, our graph mimics the slide, and it's exactly the same, but except our numbers are now closer to like 80 million now. Between 70 and 80 million but it's going up at an incredible rate. If you look at the population index for the world, okay, this is the population for the world, and you can see that is increasing, but it's being driven mainly by Africa. That's for the world, and Africa is what's driving the graph. So Africa is what's driving the graph, and you can see Europe is flat, and America, their graphs are flat. So the population for Africa, this is going up. Our population growth is expected, our growth rate has started to decrease, but that means that this graph isn't going exponential, it's still increasing. So our growth rate in Africa is going up phenomenally. And the population of Africa, you can see, is going to be massive. So how many patients have we got of Gaucher's in this country? We have 82 Gaucher's, 27 Fabry's, and Pompey's, 14 patients with Pompey's. This is an old slide showing that private healthcare in the world is actually going up, but private is going down and public is going up throughout the world. In this country, the money just gets stolen. These are the actual prices. I won't go through the prices, but the total expenditures of rare disease in South Africa for Gaucher's disease is $3.7 million. Fabry's disease, $1.7 million, and Pompey's disease, $860,000. So Helen Clark said at the United Nations Development Program that no country can claim to have achieved universal health care if it has not adequately and equitably met the needs of those with rare diseases. So it's a challenge to our community to find novel ways to be able to afford and give these to our unfortunate patients. We're very fortunate here in this country, well, in this hospital, that we fight with Graham and we get management to treat our patients. A lot of patients in the country, unfortunately, they don't get treatment and then they try and get referred here, but we've got a fixed budget. And we need to try and explain to the other hospitals they should be actually managing their own patients. We're happy to manage them, but they should give us supplies from their budget to treat them. And I think that's a very important point of managing, in that establishing a rare disease unit enables our registrars to be trained on diseases they will probably never see in their lives, so that when they do see them, they can manage them appropriately and adequately. So there's not such a rare disease, and how to tame the elephant in the room, which is the costs. And what we need to be doing is explaining to the world that they need to rediscover Africa. They previously discovered Africa, Europe, so they could take our gold and diamonds and our resources. Now, the next big thing they've got is data and population, which we have got, which they don't have. So they need to be investing more money and hopefully change the dynamic of Africa, because we remain a huge number of people that require treatment. Thank you.